for this month's film reading session. For those of you who haven't joined us before, just a very quick introduction. My name is Ian and I'm a radiologist. I graduated from the RVC way back in 2004, and after spending some time in practice and completing a PhD, I did my imaging residency, again back at the RVC, between 2013 and 2016. And these days you can find me at London Veterinary Specialists, which is the only multidisciplinary referral centre in central London. So if you need any help with any imaging cases, whether it be to discuss a patient, try and decide what would be the most appropriate imaging modality to use to get your diagnosis, or if you need a hand interpreting some radiographs, then drop me a line either via email or you can give me a call at the clinic. For these film reading sessions, they are interactive, so you guys will certainly be contributing and letting me know what you think of some of this evening's cases. The other way to get involved is to use our interactive Poll Everywhere software, and you can do that by logging in at pollev.com and entering my username, which is Ian David Joni 636. I didn't have enough room for the S to make it Jones, and what will happen is at various points during the presentation some questions will appear. You need to submit your response, and hopefully the responses will appear in the presentation and be a good point for discussion. So as is traditional for these sessions, before I open up the floor and ask you guys to interpret some of these cases, we'll take a look at an example. This is a case that we looked at last month. It's a 2-year-old male neutered domestic short-haired cat that presented with dyspnea. Because this is an example, I'm only going to run through just a single film, and I've given myself the left lateral view of this thorax to interpret. So immediately you look at this film and the dorsocaudal thorax looks abnormal, almost looks hyperlucent, and our eyes are drawn to a linear opacity that stretches right the way from the cranial thorax to the margins of the diaphragm. And not only that, but associated with this linear opacity, we've got some displacement of the trachea and the cardiac silhouette. And this linear opacity is in fact a tracheal stripe sign, which is something that we would typically see in a patient that has an enlarged esophagus, a particularly large esophagus that's filled with gas, so a megaesophagus. And this hyperlucent appearance of the pulmonary parenchyma, making it slightly easier than we might expect to see some of the margins between the adjacent structures within the dorsocaudal thorax, again would be typical of a big esophagus that was full of gas. So this patient does indeed have a megaesophagus. That's our diagnosis in this case. Because the patient has a megaesophagus, and lots of patients with megaesophagus have either vomiting or regurgitation problems, always a good idea to check for any evidence of aspiration pneumonia. So we can take another look at the ventral thorax in this case, because that's where we're going to see changes as a result of pneumonia. So infiltrate as a result of pneumonia usually has a ventral distribution. So if there was an interstitial or alveolar pattern that was there as a result of, say, an aspiration pneumonia, we would see it ventrally, typically superimposed over the cardiac silhouette. So examining that region of the thorax, don't see any evidence of aspiration pneumonia. So for this cat, it is simply the megaesophagus, so diffuse marked esophageal dilatation and filling up of that esophageal lumen with gas. And the main reason for this case being included last month was not only to review some of the changes that you might expect to see in a patient with megaesophagus, but also to think about the potential differentials. So you can see megaesophagus idiopathically, so no real reason for it. You can see it iatrogenically in patients that are either sedated or anesthetized. I don't see any ET tube in the cranial trachea in this cat, and I think this radiograph was acquired with this patient conscious, so unlikely that it's either idiopathic or iatrogenic. It could be congenital, and this was a very young patient, so potentially this could be a congenital megaesophagus. And then there are a whole bunch of other reasons why a patient might have megaesophagus, ranging from acquired conditions, things like neuropathies, myopathies, toxicities, metabolic problems. There are other neurological problems like dysautonomia in dogs, Key-Gaskell syndrome in cats. You can have hiatal hernias that sometimes will result in a megaesophagus, and various other things. So the differential list for megaesophagus is quite long. That was the main reason to include this case, to allow us to review all of the possible causes of megaesophagus. So that is our example, and that gives me a good opportunity to test our polling system. So in just a moment, I'm going to activate the first question. So for those of you who are using our polling system, you should hopefully have a question that's popped up, which is any questions about this example. That will just give me an idea of how many of you are using the system, and also whether or not this is going to work for us this evening. So I can see a few of you are taking part, which is great. So I'm going to sync this up, and we'll see if it works. Clear. Yeah, there we go. So we've got our 4 results, and everybody is happy with the example, which is excellent. That means we can move on to case number 1. So case number 1 is a 9-year-old female neutered Chihuahua that's presented to you as dyspneic. So we've got a few thoracic radiographs for us to have a look at. Given that this is an interactive session and I've done the example, any of you guys fancy taking us through case number 1?
I can do it.
Okay, great. Thanks, Pete.
So there are 3 orthogonal view of a skeletal of mature dog of the thorax, starting from the right lateral. Well, the details are adequate. We can see the cardiac silhouette that is markedly enlarged, displacing dorsally the trachea. Moving to the pulmonary parenchyma, there is a diffuse increase of soft tissue opacity around the peribronchial, the hilar region. As well in the dorsocaudal lung lobe, there is, I would say, alveolar pattern. For me, is like look like more like, yeah, more a soft tissue opacity. Then if we move to the DV view, on the cardiac silhouette is definitely enlarged, occupying like more than 2/3 of the thorax. And then you can see clearly some air bronchogram affecting both the caudal lung lobe, both on the left and right side. Moving on the last projection, there is the cardiac silhouette that is like enlarged, still this dorsally displacing the trachea. Around the hilar region, there is this increase of soft tissue opacity. I try to look at the vessel to assess the vessel. I cannot really see them on the DV view, and on the lateral view, they seems like bigger. So my main finding are enlargement of the cardiac silhouette. I would say global enlargement, dorsally displacing the trachea. This alveolar diffuse alveolar pattern affecting more the hilar region and the dorsocaudal lung lobe can be like compatible with like a fusion. So my main differential would be like an end stage of an heart disease with a possible like congestive heart failure due as well to like the large vessel.
Okay,
Yeah.
no, I think you've done a really good job. So what we're going to do now is, based on B's description, we're just going to see if the rest of you guys are convinced. So I think we can all agree that the heart in this patient is abnormal, but what I'd really like to know from you guys is whether or not you think there's any evidence of heart failure. B certainly thinks there is, so do you guys agree? So cast your votes now. Okay, so let's sync this up and we'll see what you guys think. Okay, so pretty unanimous, in fact completely unanimous. Everybody is in agreement that this patient is in heart failure, and I would absolutely agree. So I think B did a great job of describing these films. First thing that you notice is just how big this cardiac silhouette is. And as B pointed out, not only is this cardiac silhouette big and occupying a large proportion of the thorax here, it's displacing the trachea dorsally. Some of the features of this cardiac silhouette that we didn't mention might allow us to be a little bit more specific in describing which chambers are enlarged and more predominantly affected by this cardiomegaly. So as well as having a really big cardiac silhouette and dorsal displacement of the trachea and the mainstem bronchi, and we've also got some steepening of the caudal border of the cardiac silhouette here. And that's something that we see most often with left atrial enlargement. And thankfully, that's a really common change in patients presenting either with mitral valve disease or dilated cardiomyopathy, which are the two most common cardiac diseases that we're likely to see in dogs, with the small dogs having mitral valve disease and the big dogs having dilated cardiomyopathy. A lot of cats with HCM will have a big left atrium, but that's much harder to see on radiographs normally than it is in dogs, either with severe mitral valve disease or with DCM. So big heart, dorsal displacement of the trachea, steepening of the caudal border of the cardiac silhouette. And when you have these dogs with mitral valve disease that have a big left atrium, and the left atrium is superimposed over the hilar region in lateral radiographs, it's often difficult to decide whether or not that increase in opacity that you can see there is as a result of this enlarged left atrium or as a result of effusion, because pulmonary edema, which you're going to get secondary to heart failure in a patient that has left-sided cardiac disease like mitral valve disease, is going to form typically in the hilar region and in the dorsocaudal thorax. That's true for dogs, not necessarily for cats. So cats with HCM, for example, when they go into failure, the distribution of the edema is much more erratic. So you don't tend to typically get hilar and dorsocaudal edema in cats with failure. It can be patchy and occur really anywhere and everywhere. But this is a dog, and this is a dog that we think has a big heart, and more specifically, a big left atrium. So we're concerned about left-sided cardiac disease. It's a Chihuahua, so we're concerned about mitral valve disease. So it's going to have a big left atrium, which is here. And now we need to decide, okay, do we think this patient is in failure? And we're looking at the hilar region here, and we think, well, it does look like it's increased in opacity. But is this increase in opacity in the hilar region just secondary to this left atrium, or is it edema? And I think the increase in opacity that we can see as a result of the left atrium, we can almost sort of trace the margins of that large left atrium here. And so any amount of increase in opacity that we can see in this region, just caudal to the tracheal bifurcation, we just need to be a little bit cautious about interpreting, because there's a big left atrium here and it's superimposed over that region. However, as B has pointed out, it does seem that there's an increase in opacity in the dorsocaudal thorax. So this pulmonary parenchyma is more opaque than we'd expect it to be. Now, it's not so opaque in this lateral view that we can't make out some of the underlying pulmonary structures, so we can still just about see some of the vessels. surrounding the pulmonary parenchyma in this dorsal thorax in this lateral view, but it's certainly not normal. It's increased in opacity, so there's certainly some evidence of an interstitial pattern here and some interstitial infiltrate. But if we look at the DV view, again, I'd agree with B here, as B's pointed out, it looks like in the caudal lung lobes, we can see some bronchograms. So we've got these branching or arborizing radiolucent structures in the caudal thorax on the right and on the left. It's a little bit more severe on the right than it is on the left, and those are bronchograms. And if we can see bronchograms, then it means that that pulmonary parenchyma is certainly abnormal, and that there's infiltrate within the interstitium and within the alveoli, and therefore it's an alveolar pattern. And when I'm describing changes to the pulmonary parenchyma, I'd always mention the most severe change first. So I think it's absolutely justified saying there's some consolidation here and some alveolar change and an alveolar pattern that has a dorsocaudal distribution. So B is absolutely right. The other feature here that we could comment on, again, to try and be a little bit more specific about which of the cardiac chambers are enlarged, is the angle of bronchial divergence. So we've got the trachea here, and we've got the main stem bronchi coming off the trachea, and then there's an angle that is formed by the divergence of those main stem bronchi, and that's the angle of bronchial divergence. And if you have a big left atrium, so the left atrium is going to be just about here, then that's going to push these bronchi laterally, and as a result of that, the angle of bronchial divergence is going to increase. So this is where people start talking about the cowboy sign. So if you imagine that this is the back of the cowboy, and these are the cowboy's legs, the left atrium is effectively the horse that the cowboy is sitting on. And if a cowboy is sitting on a really big horse, then his legs are really splayed, and that splaying is effectively the increase in angle of bronchial divergence here. And I do think it is a little bit increased. I mean, it's a little bit bulgy, those legs look a little bit more splayed. So yeah, I absolutely agree with B, and I agree with all of you that this patient does indeed have a big heart, has a big left atrium, and it has consolidation of its lung, and that has a dorsal and a caudal distribution. And the most common reason for that would be in a dog like this, a Chihuahua, would be mitral valve disease and a left-sided failure. So I don't really have anything else to add to B's description. I think she did a really good job. The only other thing I think here is that the dog's missing a rib, so I think there are only 12 ribs rather than 13, but that's a very minor point. So yeah, in terms of other imaging modalities you could recommend to further investigate the changes that we've seen on these radiographs, then an echo would certainly help us look at that left atrium, the left ventricle, and the mitral valve, confirm our suspicions, but not before we've stabilized this patient and sorted out the heart failure here. Something that B talked about as well was these pulmonary vessels, and I agree that they don't look particularly big in any of these views. And if we remember how we tell which is a vein, which is an artery, so veins are ventral and veins are central. So in the lateral view, veins are ventral, so artery, bronchus, vein, so it's an artery, that's the bronchus, that's the vein, and then veins are central. And we can't really see them in this DV view because of all the edema that's going on in this caudal thorax, but they'd be in this sort of region here. So artery, bronchus, vein, and then artery, bronchus, vein. And in failure, we'd expect the veins to be big, so bigger than the arteries. And that isn't really something that we see here. It's not something that we would then say, well, this patient can't be in failure because the pulmonary veins don't look big. Quite often, I've seen patients like this present and have some frusemide before they get their radiographs. And I think in those patients that are in kind of early failure and have already had a bit of frusemide before they get their imaging done to try and stabilize them, often these vessels look normal by that point. And I think B's right. I wouldn't really ping these pulmonary veins as being too big and bigger than the pulmonary arteries. So there we go. I don't have anything else to add. Any of you guys have any questions about case number 1 before we move on? And you can ask them via the chat if you like. If not, then we shall soldier on to case number 2, which is an 11-year-old female neutered Jack Russell Terrier that presents to you as vomiting. And I think we've got 2 radiographs to look at here. So yeah, who fancies taking on this vomity Jack Russell Terrier? And this is its first opinion case, so this actually was a case that came in through BVetMed. So this is absolutely the sort of thing that all of you guys are going to see in practice. And there is no pressure, because this little Jack Russell is not sat on the imaging table looking up at you guys, pleading with you to make a decision about what to do, and neither is this exam.
I can have a go.
Yeah, absolutely. Thanks, Nicoletta.
So we do have 2 radiographic projection dogogram of a skeletally mature dog. One is a right lateral, and the other one probably is a DV, which is quite blurry as well, so it's not really useful. I'm wondering the dog was probably conscious, or he was not well sedated, because it's a bit blurry as well, and probably is a bit, I would say, probably overexposed. Anyway, on the lateral, regarding the thorax, is in an expiratory phase, so probably there is a bit more increased structure opacity of the lung field, and there are these multifocal sort of mineralized structures that they are essentially distributed in the right caudal lung lobe, as we can see in the DV projection. It's really difficult to see if these sort of structures, if they follow the bronchial tree, if they are at the end of it. I wasn't really sure when I had a look at the X-rays, to be honest. I mean, probably they follow the bronchial tree, or I'm not sure about it. Or if not, they are in the alveolar part in the pulmonary parenchyma, but I mean, I'm not sure about it. Regarding the abdomen, there is a massive dilation of the gastric fundus, which essentially occupies the entire costal arch, and there is some multifocal sort of mineralized material, which they supposed to be in the region of the pylorus, because this is a right lateral. There is a bit of loss serosa details of the abdomen as well, so we cannot really appreciate the contrast between the different organs. So what I can see essentially is a sort of overcrowding, overpacked of the small intestinal loops in the mid abdomen, and as well as some sort of wispy appearance at the level of the craniodorsal abdomen, superimposed to the stomach, which is quite dilated. So really lots of contrast there. There is a intestinal loop which is mildly gas filled in that area, which may be part of the duodenum. I mean, I'm not completely sure. Just immediately caudal to the costal arch on the ventral aspect, there is a sort of tongue-shaped soft tissue structure, which in the ventral aspect, which can be displayed. Yeah. Yeah, and there is this other structure which is at the level of the sublumbar region, highlighted by sort of surrounded by gas at the level of the 4th lumbar vertebra, just down there. Okay. And I cannot really appreciate the bladder, but there is superimposition of the legs, plus there is overcrowding of the loss of serosa details, overcrowding of the small intestine. Well, I think it's quite a tricky one. I mean, I'm not sure if I do have an answer.
Okay.
I would, to be honest, I would say I don't know if I'm wrong, that in the thorax, the mineralized structure that we can see, there may probably be mucus plug possible in the bronchi. I wouldn't put in differential diagnosis sort of neoplastic metastasis, because to me they don't look like, to be honest. And I would put, I don't know, I would put possibly mucus plug. And regarding the dilation of the stomach and the pylorus, I would say that there is something possibly dodgy within the pylorus, and this is possible is causing a secondary gastric dilation. I wouldn't completely rule out for embodying this dog, although there is a no. I mean, we have some small intestinal loops that are gastrulated, but not too much, and we have other that they are fluid filled. So I would think about, you know, possible for embody. And I would probably put also in differential diagnosis pancreatitis, because the dog is vomiting and there is this sort of wispy appearance at the level of the craniodorsal aspect of the abdomen. So I would probably ask for an abdominal ultrasound if it's possible.
Okay. Yeah, no, it's certainly possible. So I think at that point, and yeah, good job, Nicoletta. I agree with all of the changes that you've described, and a really nice description. So what I think I'd like to do now is to just open up the floor via the poll, and let's just see what people think that we should do next. So we could potentially do an abdominal ultrasound, but there are some other options available to us if we were maybe a little more convinced than Nicoletta that this patient has a foreign body, say a foreign body within the stomach, or potentially a gastric outflow obstruction. Then we might think about just going straight for XLAP. We could do a contrast study. So if we've got some barium lying around that needs using up, or if we have a particular passion for contrast studies, then that would certainly be an option. Or we could just take some more plain radiographs. So if we didn't have abdominal ultrasound available to us and our index of suspicion wasn't high enough to justify an XLAP at this point, then we could, and the patient was stable enough, we could potentially just take some more abdominal radiographs a little way down the line. So yeah, what do you guys think? What would you do if presented with this patient and having evaluated those radiographs? I think it's fair for me to say that the dog at this point was clinically stable. So was vomiting, but cardiovascularly stable and not in any danger. Okay, so let's have a look-see where you guys are sitting with this one. All right, so vast majority of you guys are going to go for the ultrasound, which I think is very reasonable. Some of you said that you might give it some contrast, which also reasonable. And some of you said, you know, I'm going to just sit on this patient and I'm going to maybe take some radiographs a little way down the line, which again I think is very reasonable. So we'll just take a quick look at these radiographs again before we look at some more images that we acquired from this patient. So I don't really have anything to add to Nicoletta's description. I think the main finding here is this huge stomach. So there's a massive gastric dilatation here. And as a result of this huge stomach, all of the small intestine is getting pushed caudally. So it's all bunched up in the mid and dorsocaudal abdomen. And as a result of that, it's making it very tricky to see any of the other abdominal organs. So we can't really see the bladder, we can't really see the kidneys, we can maybe see a little bit of the spleen, but nothing else. As well as the stomach being really large, there's a bit of a differential between the appearance of the material that is in the dorsal part of the stomach versus the ventral part of the stomach. So dorsally it looks a little bit more uniform, and ventrally we've got just a bunch of kind of gritty, granular-looking mineralized opacity that could potentially be in the pylorus, as Nicoletta mentioned. Now, it probably wouldn't be reasonable to call this a gravel sign in this patient, because that's something that is usually only used for small intestines, really, and in patients that have typically chronic mechanical ileus. But that's the sort of thing that we're seeing here. It's sort of mineralized stippling, almost looks a bit like grit or gravel. And as far as the thorax goes, I absolutely agree. I think we've got multiple clearly marginated, not focal, mineralized structures that are concentrated in the right caudal lung lobe. I think it is tricky to decide whether or not these are bronchial. I think they probably do follow the bronchial tree here. They're not particularly branching, but the position does match where I'd expect some of those more tertiary bronchi to be. And I agree, I wouldn't be concerned about them. I think they could be mucus flows, they could be big bronchiolis. I certainly wouldn't be getting too concerned about these structures in this patient. I'd be way more concerned about what is going on in that stomach. So in this patient, we did indeed do an abdominal ultrasound. So I can run through some of the ultrasound images that I acquired. So what we're looking at here is the stomach. So this is the stomach here, and that's the gastric wall. And this is all of the stuff that is inside the stomach. So just as we expect, the stomach is big and it's full of stuff. Doesn't really have any definitive appearance here, and certainly no evidence of a gastric foreign body in this image. And this is sort of the gastric fundus here. Gastric foreign bodies on ultrasound typically are going to be really hyperechoic, really clearly marginated, and then be really strongly shadowing. And we're not really seeing anything that's compatible with a gastric foreign body at this point. Just moving the probe caudally into the mid-abdomen, just taking a look at how some of the small bowel looks. So we've got lots of different loops of small bowel here, and they all look absolutely fine. So they're pretty empty, and there's nothing to suggest that there's a mechanical ileus here, where we'd expect maybe to see two distinct populations of small bowel. There's nothing to suggest there's anything sinister like a linear foreign body, for example. We would expect to see plication of the bowel. Those look like a pretty happy group of small intestines. So this is really the area that I was most interested in evaluating in this patient. So we've got a dog that has a huge stomach, and in the lateral abdominal radiograph, we've got an accumulation of kind of gritty, gravelly looking material in the cranioventral abdomen that might correspond to material within the pylorus. And if you have a patient that has a huge stomach and there's really any suggestion that there's anything going on in the pylorus, then you need to be concerned about a gastric outflow obstruction. The right lateral view is not always the best to evaluate the pylorus. So the pylorus is on the right side, so really you want to ideally get a left lateral view, so all of the gas goes over to the right and highlights any foreign bodies that might be present within the pylorus. In this case, we didn't take any additional radiographs. We went straight in with the abdominal ultrasound. So just to kind of orient you guys in terms of what we're looking at here. So this is gastric wall here, and this is duodenum here. And this is where duodenum meets stomach. So this is the pylorus, and there's absolutely nothing stuck in that pylorus. There's no foreign body there. If there was, then we wouldn't be able to get this image. There'd just be something hyperechoic and heavily shadowing in this region. And a lot of gastric outflow obstructions that I've picked up on ultrasound, particularly in dogs, have been fabric or linear foreign bodies that get stuck at the gastric outflow here. So you get a big wodge of fabric in this region, just at the level of the pylorus, and then you get strings from that fabric extending through the pylorus into the duodenum, and then the duodenum looks very plicated. But none of that in this dog. That is a pretty normal looking pylorus, so no gastric outflow obstruction. And that's just me helping out by popping some arrows on the pylorus. So again, this is the image that you really want to get when you're evaluating the pylorus and you're trying to decide whether a patient has got a gastric outflow obstruction. And the way to get it, if they're in right lateral, is you really need to get right up underneath them and ideally find the duodenum So when they're in right lateral, find the right kidney, and then sort of fan dorsally and cranially and slide a little, and you should be able to find the duodenum. Then follow the duodenum up to the stomach, and the point where the duodenum attaches to the stomach is the pylorus, and that's what it looks like. And that's a normal pylorus. So this dog, it essentially just had a big gastric dilation. This dog was just put in a kennel and kept an eye on, and was given some symptomatic medical treatment overnight, and it did absolutely fine and went home without anything else needing to be done to it. So yeah, well done, you guys. So nobody suggested that we cut this dog, which would maybe have been a little bit premature in this case. And yeah, everybody suggested we do some additional imaging, which was absolutely the right thing to do. So we did abdominal ultrasound. I think if you had taken some repeat plain radiographs, then what you would have seen is that stomach just gradually emptying, essentially, because yeah, the dog remained absolutely fine and clinically stable throughout, didn't really do any more vomiting, and I think went home maybe 12 hours, maybe 18 hours after those radiographs were taken. So yeah, that was a tricky one, because yeah, I was maybe thinking that some of you guys might fall into the trap of going straight for the scalpel, but that wasn't to be. You guys all did a great job of being cautious and suggesting some additional imaging before reaching for the scalpel. So yeah, nice job. Okay, anybody have any questions about this case? If not, then we will move on. So this is case number 3. This is a 6-month-old male entire cockapoo. It's presenting with an intermittent fall in lameness, and on physical exam, it has some mild but repeatable elbow pain. It's both the elbows that seem painful. So we've got some orthopedic films for you guys to have a look at. So we've got the right and the left antebrachium, essentially. So we've got elbow and carpus for you to have a look at. So yeah, anybody feeling in an orthopedic mood this evening? And this is kind of a fun case. Nobody feeling particularly orthopedic. If nobody is as a desperate urge to present this one, then I might see if B is feeling ambitious, because I know that B is familiar with this case. She has presented one already, so it's a little bit unusual to have to present 2. But do you think you might be willing to present this one, B?
Yeah, I can do it.
Great, thanks.
So,
okay.
There are 2 orthogonal projections of both elbow in a skeletally immature dog. On the lateral view, there are no major changes that I can point at. But if you look at the antebrachial view, there is like a decrease in the bone density in the distal part of the humeral head, affecting bilaterally the joint.
Okay.
Then the feces are still open. This like decrease in bone density is, I think you can point it better on the left side rather than the right, because on the right side is like superimposed with the ulna, but you can still see.
Okay.
Looking at the lateral, I cannot see any major changes on the lateral view. So, well, because it's affecting like bilaterally, is most likely to be like a congenital problem, and the main my main differential will be like an incomplete ossification of the humeral head of the distal part of the humeral. I think it's called condyle. Yeah, the disease. Yeah.
Okay. All right.
And the next step would be like do a CT to like see if in a three-dimensional view if you can like see the lesion or like have more information.
Okay, no, I think that's all pretty reasonable. So be not too concerned about these lateral views, but is pretty convinced that there's something affecting the left and the right humeral condyles. So what I'm going to do is I'm just going to open up the floor while you guys just take a look at the right and the left craniocaudal views of these elbows. And just ask you guys whether you agree with B. So do you think that there is something going on here in these humeral condyles? Or do you think these elbows are pretty normal and the problem is somewhere else? So for those of you who are using our Poll Everywhere software, hopefully the question should have appeared, and yeah, you can give your two penneth. Do you think these elbows are normal and the problem is elsewhere, or do you agree with B? Do you think, you know what, that there is something funny about these humeral condyles? All right, so I've got a few of you responding, which is great. So we're going to just sync up. See if B has managed to convince you. Okay, so be very persuasive. So everybody happy that these elbows are indeed abnormal and there is something going on. And I would absolutely agree with B that it's the humeral condyle that we should be concerned about. In terms of describing the abnormalities here, I wouldn't necessarily say that there was a lucency, a generalized lucency. So when we're talking about bone and we're talking about generalized lucencies, it sort of implies lysis. And when you start talking about bone lysis, it essentially implies that there's an aggressive bone lesion. And you know, in this 6-month-year-old dog, that isn't really where we're going. What we've got here is a sagittal fissure that's extending from the articular surface of the elbow right the way through to the supratrochlear foramen, and it's bilateral, and associated with this sagittal linear lucency, we've got potentially some discontinuity of the articular surfaces as well. There isn't really much else going on, but these linear lucencies, these sagittal fissures, would probably be the best way to describe them. You wouldn't expect to see that in a dog that was 6 months old. So the humeral condyle forms from two separate ossification centers, and those centers are usually fused by 6 months. So to see a fissure separating the medial and the lateral part of the humeral condyle would certainly be abnormal. So something like an incomplete ossification of the humeral condyle would definitely be our top differential here. So in order to convince you guys still further, we can take a look at a CT scan of this patient. So let's just run through this. This is a 0.6 millimeter bone reconstruction of this little doggie's elbows. So just moving caudally towards the elbows, and here we have the elbows, and I'll just pause it there. So hopefully you guys can appreciate that there are indeed two really large sagittal fissures bisecting both the left and the right humeral condyle, and they absolutely shouldn't be there. So this dog does indeed have incomplete ossification of the humeral condyles. So it's a really important thing to be familiar with and to pick up, because these dogs that have incomplete ossification of the humeral condyles, they're predisposed to condylar fractures. So If you don't pick this up sooner rather than later, then it's much more likely that a dog like this, when it has any sort of trauma to that elbow joint, might fracture that humeral condyle. And it's much easier to stabilize these humeral condyles now than it is to repair a condylar fracture. And they can be tricky to diagnose because in these skeletally immature dogs, you've got all sorts of lucencies bisecting these bones because of all the open physes. And in this craniocaudal view, as B pointed out, the bit that you're interested in is sort of completely superimposed by that ulna. If you don't have access to CT, then you could potentially think about getting some oblique views, but it can sometimes still be quite difficult to see these fissures. But this dog does indeed have two fissures. It does indeed have bilateral incomplete ossification of the humeral condyle, and we can see that very nicely on this CT scan. So let's just look at it one more time. I'm not going to pause it this time. We'll just run right the way through it. So we're moving towards the elbows, and then we can see the condyles and the fissures, and that is pretty convincing. So yeah, nice job. So for those of you who aren't too familiar with that condition and maybe haven't seen radiographs or CTs of young patients with incomplete ossification of the humeral condyle, that's one, and that's what it looks like. All right, any questions about this one before we move on to case number 4?
Can I ask a quick question?
Yeah.
On the right elbow, on the mediolateral view, I thought as well, but because you have a superimposition, so it's quite difficult to say, at the level of the dorsocranial aspect of the anconeal process, so there was probably a fissure line, but because there is all this superimposition, I mean, I wasn't sure, and then with the CT, I mean, it's not. Yeah.
No, I absolutely agree. I think you're right. It does look like there could be a little fissure there. So Nicoletta is concerned that there might be an unattached anconeal process in this right elbow, and I think that's justified. I think that's another reason to potentially put this dog through the CT. You can sort of in the left you can see it here, but it's more convincingly part of the distal humeral physis here.
Yeah, I wasn't concerned on the left. I was more concerned on the right. But then I thought you cannot have, a double condition.
Yeah. So I think it is. I think it's this physis here that's masquerading as potentially a little fissure, looking a bit like an unattached anconeal process. But no, good spot. I think you're absolutely right to ping that. And yeah, describe it and have that on the differentialist. I mean, can we completely rule that out on these radiographs? Not completely. I mean, looking at the left one and comparing, I'd be more convinced it was just superimposition of this physis, but I think it'd be a reasonable thing to include in the report, certainly. Cool. Any other questions about this little puppy? All right. So let's move on to the final case of email, which is an 8-month-old Pomsky, as female neutered. It's only been spayed very recently. Now, the spay was a tricky one. So during the op, we weren't able to identify the left kidney or the left ovary. And since the spay, this dog has continued to show signs of oestrogen coming into season. So there's a suspected left ovarian remnant. And what I've given you is a couple of radiographs. So you've got a right lateral. I think that's probably DV. Okay. So who fancies case number 4? And again, it'd be good if we could get somebody different to have a pop at this one. Like I said, there's no pressure. I don't want to keep relying on B and Nicoletta to contribute. Anybody fancy this one?
I'm happy to give it a go.
Yeah, that'd be great.
So we have 2 abdominal projections of the abdomen. The X-rays are not great quality. And on the lateral right, we can see a poor serosa detail The liver lobus is slightly beyond the rib cage. There is gas in the small intestine, and there is a soft tissue opacity on the craniodorsal aspect going towards the left side. If you look at the VD view, there's also a linear structure in the caudal dorsal aspect of the abdominal cavity, and is surrounded by a loss of serosa diesel. I cannot see the bladder, and the other structures, like the extra-abdominal structures, look normal. So with the clinical history and the findings, obviously, I will be concerned about that linear structure. Could be possibly compatible with an abdominal swab left inside the animal during the surgery, and possibly having some peritoneal reaction around it. I'm not so sure what's going on with that soft tissue opacity. I can't visualize the kidneys very well. I cannot see the outline of the spleen either, so I would probably recommend to perform further tests to confirm diagnosis.
Okay, yeah, no, I absolutely agree. So the thing for us to focus on here is what is that? It is linear. It is very sort of coiled up, if it is something linear, and it is really tricky to work out where that structure is. So we can see the descending colon here in this view, and the structure, as you've very nicely described, it does have a soft tissue opacity surrounding it, and it's sort of adjacent to the colon here. And then we've got more soft tissue opacity just cranial to it, running up the left side of the abdomen here. And it's pretty tricky to know what that is, and whether that's related to this thing, whatever this thing is, and how it all fits together. So yeah, kind of a weird one. So what we'll do before we talk about it anymore is, yeah, just to see what you guys think we should do next. Christina suggested that we do some further imaging. I think that is reasonable, but if you guys feel differently, and you think there's something else that you would do, then you can choose from the options that I've given you. And I'll just give you a moment to respond. Okay, so let's see. Yeah, so we've got somebody pretty convinced that they know what's going on, and they take this patient to theatre, and then the vast majority of you guys saying, you know what, I think I'd probably like to stick the probe on this dog before deciding what else to do, and I don't think that's unreasonable. And as a result of that, we've got some ultrasound images to take a look at. I don't have too many images saved from this ultrasound, but if I can just try and explain what's going on here. So one of the things that was super important from the radiographs is just to be absolutely sure that this structure is either peritoneal or retroperitoneal, and it isn't within the lumen of the GI. So this isn't something that has been eaten and is just in the lumen of the descending colon. Now on the radiographs, it very much looked like it was adjacent to the colon rather than within it, but just wanted a little bit of reassurance as to exactly where this structure is likely to be. And here, this structure here is the descending colon, so that's the wall of the colon. That's a little bit of gas within the colonic lumen, and this is the structure that we were seeing on the radiograph. So this is that structure that has that sort of really opaque, coiled up linear thing within it. On ultrasound, it's very hyper echoic, and it has all of this really strong acoustic shadowing associated with it. So the question is, what is it? So this is the descending colon here, and this is our structure. What is it? And Christina has already suggested a possible identity for this structure. As well, could this be a swab that's been left in following the spay? So is this something like a gossipiboma? And the answer is, yeah, you're absolutely right. This is a swab that has been left in the abdomen following the recent ovarian hysterectomy. And this linear sort of coiled, opaque structure that we can see is a lot of swabs have got contrast woven into them effectively, which makes them very easy to see on radiographs. And that's what this is. So the kind of coiled up linear stuff that we can see here, it's really super opaque. I mean, it's almost more opaque than the bone. So it's getting towards being as opaque as barium or having a metallic capacity. And that's because that's the contrast that's been included in the swab to make it really obvious on radiographs. So that's pretty typical of a swab that's been left in the abdomen and a gossipiboma. We're not seeing too much of a loss of peritoneal serosal detail. I agree that it isn't completely normal, but we're not seeing a huge amount of maybe effusion. We didn't see a lot of effusion on the ultrasound. And in terms of the increase in opacity associated with the structure, and particularly down the left side of the abdomen here, I wonder whether that's just inflammation within the retroperitoneal space. So this is our swab, and this is the contrast within the swab that makes it easy to see. And then this is all just a really angry left retroperitoneal space as a result of that swab that's been left behind. So we can see what that looked like at surgery, because after doing the ultrasound, this patient did go to surgery, and the swab was taken out. So to orient you guys, this is the colon here, I believe, and you will correct me if I'm getting this wrong. And this is the swab here. So that's a swab that's been left behind after the spay surgery. And that's how it looks on radiographs, and that's how it looks on abdominal ultrasound. So the reason why this case has been included is I think it's super important that you guys know how to recognize this when it happens on radiographs and on ultrasound, so that you can correct it as quickly as possible. Mistakes happen, and I mean, this just illustrates how important it is to do a swab count, even for routine surgeries like ovarian hysterectomy. So yeah, this was a retained swab that was removed. Mr. Pomsky is doing absolutely fine. Any questions about case number 4 before we finish for the evening, or any of the cases that we've covered this evening?
What about the left ovary?
In terms of the
And
left
the
ovary,
kidney.
I think I can maybe ask B about the left ovary and the kidney.
So we take, it wasn't there, and there were no even like left kidney, so probably the dog was like.
So it was a congenital thing, essentially.
Yeah.
Okay.
Yeah.
Aplasia. Okay.
Yeah. So there we go. So not a case that you really want to see, but like I say, these things happen, and if they do, you need to be able to recognize them. And hopefully, you guys, having seen these images now, yeah, if you do see one, then you ain't gonna miss it. You know exactly what it is. Any other questions about any of these cases? And if not, I will leave you guys to the remainder of your evening. The sun pretty much has gone down, so we've missed the best part. Thank you very much again for joining me. We'll do another one of these film reading evenings next month. So yeah, I hope to see you all again in May. So thanks again, and yeah, I'll hopefully see you all again next month. Okay.
Thank you so much.
Thanks, guys.
Thank you.
Bye-bye.
Ciao.
Bye. Ciao, ciao.
Ciao.